Hello dear students, today we are going to learn about acute epiglottitis. Epiglottis is a leaf-shaped structure above the laryngeal inlet and it protects the laryngeal inlet from the aspiration of food during the swallowing of the food. This elastic cartilage or epiglottis lies behind the hyoid and hyoid bone and the thyroid cartilage, and it attaches to the hyoid bone with the help of hyoepiglottic ligament, and it attaches with the thyroid cartilage with the help of thyroepiglottic ligament. Its anterior surface is lined by the stratified squamous epithelium, which is non-keratinized, and the posterior surface is lined by the respiratory epithelium, and respiratory epithelium is the stratified ciliated columnar epithelium. It is supplied by the internal laryngeal nerve, which is a branch of vagus nerve, and its function is to protect the airway during the swallowing. Acute epiglottitis is a rapidly progressive bacterial infection which cause the inflammation and edema of epiglottis, and along with the adjacent supraglottic structures like aryepiglottic folds and arytenoids, and it leads to the life-threatening airway obstruction. Thus, it is a medical emergency. Etiology in children, Haemophilus influenzae B, but its incidence has been reduced after the vaccination. In adults, the common pathogens are Streptococcus pneumoniae, Staphylococcus, and Streptococcus pyogenes, Neisseria, Klebsiella. In immunocompromised patients, Candida and Pseudomonas can be associated with it. Peak incidence is around the 2 to 7 years of age. In adults, it affects especially the immunocompromised patients. There is no gender predominance, and it is slightly more common during the winter months. Pathophysiology involves the infection by the bacteria, which causes the inflammation and edema of the epiglottis and supraglottic tissues, followed by the rapid swelling and narrowing of the airway, leads to the inspiratory stridor, respiratory compromise, respiratory distress, and it can progress to the complete airway obstruction within hours if not treated. Risk factors include the lack of Haemophilus influenzae B immunization, immunocompromised states like diabetes, alcoholism, elder patients, post-splenectomy, post-chemotherapy, post-transplant patients, trauma like thermal or chemical injury to the epiglottic structure, recent upper respiratory tract infections. Clinical feature: the child usually appears toxic with history of high-grade fever and severe sore throat, with a sudden onset of high-grade fever, and there is muffled hot potato voice, which is a characteristic sign of it, and other characteristic sign is the drooling of saliva and dysphagia. Respiratory distress leads to the tachypnea, and respiratory distress is due to the inspiratory stridor. Child usually take the tripod position. Tripod position means he or she takes sit with leaning forward, the neck extended, chin thrust forward. It to reduce the respiratory distress, the child acquire the tripod position. Cough usually absent in the acute epiglottitis, or it may be minimal. Anxiety and toxicity: patient look very toxic and very anxious. Examination should be throat examination should be avoided until the airway management, because it can precipitate the total airway obstruction. And if visualized, a cherry red swollen epiglottis can be seen, especially in the controlled settings like in operating room, and supraesternal and intercostal retractions can be seen due to the respiratory distress. Cyanosis can be seen in advanced disease. Differential diagnosis include the crop, peritonsillar abscess, retropharyngeal abscess, diphtheria, and angioedema. Crop, there is history of barking coughs, low onset of fever, viral prodrome, and patient look less toxic. Peritonsillar abscess usually presents with the unilateral neck swelling with the uvular deviation. Retropharyngeal abscess presents with the neck stiffness, posterior pharyngeal wall bulge. Diphtheria, you can see the pseudomembrane and history of gradual onset of the uh, disease. And in angioedema, there is history of allergy, swollen lips, swollen tongue. Investigations should only be done after the proper airway management, and it includes the lateral neck X-ray, where we can see the um, thumb sign, which is the swollen epiglottis. It resembles like a thumb projection or thumbprint. Here in this picture, we can see this hyoid bone, and behind this hyoid bone there is a swollen edematous structure, which is the epiglottis. And in operating room, direct laryngoscopy can be used to see the cherry red swollen epiglottis during the intubation. And CBC shows the leukocytosis. Blood culture may yield bacterial growth, and epiglottic swab can be taken after the securing the airway. Most important is the management of the airway during the acute epiglottitis, and throat examination should not be attempted until unless there is proper airway management is done. And airway management should be done only in the operating room, because there may be a need of anesthetist and ENT surgeon to do the immediate or emergency tracheostomy if there is a failure of intubation. Oxygen should be given by the nasal cannula initially or the blow-by method. Controlled intubation can be tried or done by experienced intubation expert by the nasotracheal or orotracheal routes. If failed, emergency tracheostomy or cricothyrotomy can be done. Sedation and agitation should be avoided. Medical management: after the proper airway management, medical management should be started. It includes the empiric IV antibiotics like ceftriaxone, cefotaxime, vancomycin. Duration should be continued till 7 to 10 days, and then IV antibiotics can be switched to the oral antibiotics. Adjuncts include the IV fluid, oxygen, antipyretics, and steroids can be given to reduce edema. Some studies also showed the role of the nebulized adrenaline, but it has limited role. Prognosis is excellent if airway management done properly and early. Mortality is less than 1% if prompt airway and antibiotics started. However, the delayed diagnosis, delayed management leads to rapid asphyxia and death. Prevention can be done with the help of the Haemophilus influenzae B conjugate vaccine, which can be given as per the universal immunization program during the second, fourth, and sixth month, then booster at 12 to 15 months, and proper education of the family members to recognize the airway distress. Now come to the key differences between the epiglottitis and CRAW. Epiglottitis is a bacterial infection by the H. influenzae B, and crop usually associated with the parainfluenza. Starts to progress suddenly within hours. Crop usually a gradual disease. It takes days to progress, and in epiglottitis there is no cough or minimal cough. However, in the crop there is a barking cough, which is a characteristic sign of this disease. Drooling of saliva is very common finding in epiglottitis because of difficult swallowing. In crop there is no such problem, and so the drooling is absent. In epiglottitis, patient has muffled or hot potato voice. In crop, patient has hoarseness of voice. Stridor is inspiratory in epiglottitis, and it is biphasic in crop. X-ray sign shows the thumb sign in epiglottitis due to the edema of the epiglottis. However, in crop there is steeple sign, like the steeple of church. We can see the air inside the trachea, and um, patient of epiglottitis appears toxic, and patient of crop appears non-toxic. So that's all for today. Thank you.